everyone. Welcome to Street Ultrasound. My name is Julia Guo. I am an emergency medicine physician and a ultrasound faculty with UT Health Houston. I am part of the Street Ultrasound team. My team and I made this lecture with the hope that it will help you get started with your ultrasound skills in the pre-hospital setting. This course is meant to serve as a foundation to your hands-on sessions. So it is very important that you watch this video and do lots of hands-on practice. So let's get started. So today we are going to talk about why we want to use ultrasound in the pre-hospital setting and the basic ultrasound language, the fast exam, lung ultrasound, as well as cardiac and inferior vena cava. So why ultrasound? Why do we even want to do this in the pre-hospital setting? Well, all of y'all have this on your trucks, right? Life pack, we have our glucometer, we have lots of devices. But again, we're working in a very resource limited setting. So ultrasound is another portable device that can help you out in this in the pre-hospital setting. It can give us quick answers when time really matters. And we can help to incorporate ultrasound into cardiac arrest. Another thing is that you're going to learn how awesome ultrasound is through this lecture and your hands-on courses. But I want you to remember that don't forget your basics. Don't get so caught up with ultrasound that you forget to do your basic assessment on the patient. All right, so let's talk about the ultrasound language. So in ultrasound terminology, hyperacoic means more echo, right? Ultrasound is the image is generated from sound waves. And when you say hyperacoic, means more sound waves. The more sound wave, the brighter the image. So hyperacoic means brighter. On the other hand, hypoechoic means less sound waves, less echoes, so it's darker. Isoechoic means equal brightness. Anechoic means no echo, which means black on the image. So for example, fluid in the belly, such as blood, urine, ascites, or bile in the gallbladder, will appear as black, which is anechoic. So here, let's do some practice. So we have this thing inside this bladder, okay? This thing inside the bladder is hyperechoic compared to the fluid inside the bladder, which is urine. And here, we would call this anechoic. All right, and if you look at the abdominal wall here, this stripe here is more hyperechoic compared to this stripe here. All right, and then this stripe is hypoechoic compared to here, right? So again, urine is black, which is anechoic. All right, another thing that you should be mindful of is the gain. So on the ultrasound machine, there's a button called gain. Imagine gain as the exposure of a photo. So when the photo is overexposed, you're going to have something like this. It's too bright to see the details, right? On the other hand, if the image is underexposed or when the gain's too low, then you're not going to see much. Everything is too dark. So when you're doing ultrasound, make sure that you set your gain somewhere in between this so you can see properly. All right, moving on to depth. So here is a picture of the heart, and we're trying to evaluate the heart. But what is all this down here? Well, this is all extra space that you don't need. So you want to decrease your depth, aka you zoom in, right, to here, and you end up with image like this. Now that the heart is much easier to see and you got rid of all the extra space on the bottom that you don't need. So gain and depth are two things that you want to make sure it's set up properly on your machine when you're ultrasounding. All right, moving on to holding the probe. So this is your probe. This is your ultrasound gel. And when you have this and you're trying to ultrasound a patient on a moving truck or when CPR is ongoing, well, you will slip away. What I mean by that is you're trying to look for the heart, for example, and suddenly the heart will disappear because your hand slipped away before you noticed. So I want you to remember this. So imagine you're holding your ultrasound probe like you're playing pool, okay? When you're holding the probe, part of your hand or a finger or your pinky, something has to be anchored onto the patient so you don't slip away, okay? And we're gonna have all you practice this during your hands-on session for sure. All right, now this is the tricky part. A lot of new ultrasound users are kind of lost when they're trying to imagine what they're looking at. So I'm gonna help get you oriented, okay? So this is your ultrasound probe here, and then this line here on the side, and when you're ultrasounding, you can feel this line on the probe itself. This is the indicator, so it indicates which direction your probe is pointing towards. Also, I want you to imagine your ultrasound probe like a flashlight. So now, this is the patient, the head is here, feet is here, patient is supine. The indicator is pointing towards the head side of the patient, right? Pointing towards the head. So now, when you have this image here, head is this way, aka cranial. Feet is this way, aka caudal, right? And then now, look at your ultrasound probe here. Imagine this. Your probe is touching the patient's skin, right? And underneath the skin is the abdominal wall muscle, and then you're going to run into the liver, right? So imagine you're shining a flashlight into the patient. So now, this is your ultrasound probe on top, right here. So the first thing that your flashlight goes through is the skin, and then the abdominal wall, and then the liver. And then most medial to the patient is the spine, which is here, okay? So just think about this. Your indicator is pointing towards the head. So head matches on this side of the screen. Feet are this way, and this is whatever your probe is touching is always on the top, and your flashlight is shining away, so it's shining towards the medial side of the patient, okay? All right, moving on to the 4 cardinal movements of ultrasound. So when you're during your hands-on session, your instructor will frequently use these words to try to help you get navigated. So the first movement is sliding, which is pretty self-explanatory. You're just sliding up and down, left to right, just what it sounds like. Next one called tilting, aka fanning. So I want you to imagine that you're using a paper fan, okay? So you're moving the tail back and forth, okay, and then you're fanning. The next one is called rotating. So imagine a figure skater, you're spinning, so you're rotating the probe clockwise, counterclockwise. And the next one is called rocking. You're rocking side to side. All right, moving on to basic echocardiography. And notice the word basic. We're not doing anything fancy that the cardiologists are doing. We're looking for, things that can help us change our management in the field. Okay, such as, do we even have a heartbeat, right? So our basic echocardiography is going to help us answer those questions. All right, so here we have an ultrasound probe with the indicator. And here is a man with a clock. So I'm going to explain what this means. So remember that our heart sits in the left side of the chest, right? And our heart is one of those organs that's not exactly up to down or left to right. It actually sits tilted in the left chest, right? I want you to remember this when we're doing the heart cardiac ultrasound, okay? And I want you to remember this clock. So the patient's right shoulder is 10 o'clock, patient's left shoulder is 2 o'clock, their elbow is 3 o'clock, and their feet are 6 o'clock, okay? Again, the heart sits in the left hemithorax in a tilted direction. Okay, so now I'm going to put all of that in context for you. So for basic echo, we have 4 views that we're looking for: the parasternal long axis, the parasternal short axis, the apical forechamber, the subxiphoid view, and if we tag on the inferior vena cava, that's going to be 5 views. Okay, so for the parasternal long axis, parasternal meaning we're next to the sternum, right? Here's the sternum of the patient, we're next to the sternum. And long axis, remember what I said before, the heart sits tilted in the left chamber, kind of like this. So in order to get a long axis of the heart, we want to slice it onto the long axis. Well, our indicator got to point towards 10 o'clock, the patient's right shoulder, okay? Plus or minus around 10 o'clock, okay? So when you do that, you're going to get something like this, okay? So remember what I said before, the right ventricle is the most anterior chamber of the heart, and your ultrasound probe is touching the skin. So skin here, the chest wall is here. So this most anterior chamber of the heart, this is the right ventricle. This is the septum between the ventricles. So then this makes this one the left ventricle right here, okay? This is the left atrium, and the valve in between that's flopping right here is the mitral valve. And then this is this valve right here, that's the aortic valve. And then this is the aortic outflow tract, okay? And here, this circle right here, this is the thoracic descending aorta. So just to review some basic physiology, your blood returns to the heart. It goes into the, it goes into the left atrium, through the mitral valve, into the left ventricle, out of the aortic valve, and out of the aorta, okay? And then this is the right ventricle, again, right here. And notice on this view, the mitral valve is opening and closing. It's almost tapping the septum right here, right? This is an example of a heart that's squeezing decently well, okay? Now look at this. This heart is barely squeezing, yeah? So one more time, look right here, right? It's a heart that's squeezing well. Look again, barely squeezing, right? So this is a pathology that we can find. This is something called severely reduced ejection fraction. Okay, so you're going to see this in our CHF patients. So again, this is the left atrium, mitral valve, left ventricle, aortic valve, aorta, right ventricle. Okay, you don't really see right atrium on this view. And here is the thoracic descending aorta. Okay, so if you're seeing a patient in the field with an EF that looked like this, and they had all those B lines, right, worrisome for pulmonary edema, well, if you combine these two images together, then you should be worried about a CHF exacerbation, right? Flash pulmonary edema. This may be a patient who will benefit from some nitroglycerin, okay? All right, moving on to the subxiphoid view. So you want to palpate for the xiphoid. And then again, the indicator is still at 3 o'clock. So we just move the probe from here to here, but still maintain 3 o'clock. Also, I want you to get very, very comfortable at this subxiphoid window. The reason is this is probably one of the best views that you can get if CPR is ongoing on the chest, right? Or if there's a pneumothorax, or if there's a lot of like crepitus and patient has a lot of wounds like on the chest, well, this is your view to see the heart. Okay, so get comfortable with this view. All right, so here, again, the ultrasound probe is touching the skin, and you have the abdominal wall, and you have liver, right? So this is basically the same view that we did for the FAST exam. The right ventricle, which is the most anterior chamber of the heart, interventricular septum, left ventricle is here, okay, and the left atrium, and then the right atrium. Okay, this is, I don't see any large pericardial effusion around the heart. Okay, again, the pericardium is hyperacoic. See that? Okay, how about now? What do you see? So this anechoic stripe all around the heart. Yeah, so this is concerning for a pericardial effusion. Okay, so in medical patients, this may be a cancer patient with malignant pericardial effusion. It could be a ESRD patient, a lupus patient, many things that can cause pericardial effusion. But in a trauma patient, again, this is worrisome for blood around the pericardium and causing obstructive shock. Okay. All right, look right here. Look very closely. Again, you got the liver, the pericardium, okay? Right ventricle, left ventricle, right atrium, left atrium. What do you see? Look closely. What is that? There's something bouncing in the right heart, yeah? That doesn't look normal. So this is actually a clot in transit. So this is a blood clot, okay? And it's in the right atrium. So it's just waiting to flow from the right atrium into the right ventricle, and the right ventricle is going to squeeze it right into the lungs, and this is going to be a PE, right? So if you see this in a cardiac arrest patient, well, patient probably already has a clot in their lung, okay? So this is worrisome for a PE causing the cardiac arrest. Again, this is a clot in transit, okay? Okay, how about now? Liver, we got a heart, pericardium, okay? Right ventricle, left ventricle, right atrium, left atrium, okay? You're gonna say, well, this heart is barely squeezing, right? So this is what you may find in a cardiac arrest patient. And all these wiggle that you're seeing, that's probably VFib. Yeah, you're actually seeing VFib with your bare eyes. And then you might ask, what are all these like twinkling stuff in the right ventricle? That's actually probably agitated like saline. So if patient has IV going, like you're gonna see this in the right ventricle. Whether or not this patient's alive or dead, you're gonna see some gas bubbles in there. It's probably from the IV. Okay. So notice how helpful this subxiphoid window is, right? So really get comfortable with this window, especially if Lucas is jamming on the chest. This is probably your only window that you're gonna get. All right, so in summary, today we talked about why we wanna do ultrasound in the pre-hospital setting. We talked about the ABCs of ultrasound. So hopefully this lecture will get you started with your ultrasound skills, and make sure that you do lots and lots of practice. And one advice I could give is that, learn what normal looks like. And that's how that's how you catch abnormals, right? You have to know what normals look like before you catch all the weird ones. So do lots and lots of practice on each other. All right, and then happy scanning, everybody. If you have any questions, feel free to reach out to us. You can find us on our website. You can find us on Instagram and Twitter as well. Okay.